Good morning, everyone. My name is Yong Hui. I'm one of the spine consultants from Singapore General Hospital Orthopedic Department. It's my pleasure to moderate this morning session, and I welcome all participants to this webinar. We have a very healthy audience number. People are still coming in. We'll do a quick introduction of today's webinar. June is actually the World Scoliosis Awareness Month, and scoliosis is generally defined as a curved side curvature of the spine. And I think it does affect a certain proportion of our population, from the young to the old. And we are all very concerned about how this condition affects our daily activities and our function. So today we'll find out more from our esteemed speakers. I think the whole purpose of this webinar is to create more awareness, and at the same time we want to know more about this condition, early detection, and what are the treatment options, including conservative options and surgical options. Not everyone will require surgery, and we will see who are the patients who will benefit from surgery. And today we have three speakers, starting off with Professor Ruben So, who is our senior consultant from Spine Service Orthopedic Surgery. He has a vast experience in treating scoliosis, patients with scoliosis from the young to the old. And I think we are okay to start. Oh, so if you have any questions, please type it into the Q&A box, and we'll try to answer all your questions to the best of our ability. All right. And I think without further ado, we will welcome Professor Ruben So to tell us about the advances in the treatment of adolescent scoliosis. Dr. Ruben.
Thanks, Yong Hui. And so I want to first of all welcome everyone who can join us here this Saturday morning. I know it's a bit of a wet morning, and hopefully everyone's in the comfort of your home. I'll share a little bit about the patient journey in advances, and of course, later on my colleagues will talk a little bit about adult deformity, and also we have Dr. Jun Kwek, who will share with us what happens in the physiotherapy for patients with scoliosis. So, of course, thanks to Yong Hui for the quick introduction about scoliosis. We know that it's more than 10 degrees in terms of measurement in the bending in the film from the front of the spine. And that actually works out to be this kind of angles. And of course, some patients have one curve, some have two, some have three. But essentially, there is a what we call a alteration in the normal shape of the spine in all three dimensions: the side profile and also the rotational profile. And this is why the patients complain that actually, hey, my shoulder is higher, my back is higher on one side than the other. It is also definitely, we recognize that every patient has a different type of shape of the spine, but more importantly, there is alteration in terms of the shape of the spine during scoliosis, right? And once, of course, if you want to be very clear about what we are talking about, patients who have a lot of bending forward, that will be kyphosis, or what we call a hunchback. Kyphosis is a very straight back. And most of our patients actually in Singapore who have scoliosis have quite a straight back in terms of the side profile. And this is partly because of our patient population being a little bit more slimmer and in this kind of morphology. But more importantly is when the patients are seen at the school service, the rotation of the spine is the one that affects the shape of the shoulder. And as a result of that, that's how the school health service picks them up from a screening program. So our patients in schools are picked out from primary 5 all the way until secondary school. It's been in place for many years. Our health promotion board is an important partner for us to help us in making sure that the patients are seen when they need to be seen by the specialists, but they do all the groundwork with nurses in school. So After seeing these patients, in the school, what happens is that a scoliometer is placed on the patient's back, and because of the rotation of the spine, the scoliometer may change its rotation. And we use this number as a screening program to see the patients. And in the school health service, of course, then if they require specialist care, will be referred to the three hospitals, SGH, KK Hospital, and the National University Hospital. There are many types of scoliosis, and most of the patients, and I think many of the participants, kids on this video, you have adolescent idiopathic scoliosis because it's really the most common. There are many other causes, and of course, what do we know what is the real cause for AIS? No, we don't know yet. There is, of course, congenital causes, that means they're born with it. Some patients who have neuromuscular problems can be born with issue who have because of the muscle imbalance. And of course, it's associated with syndromes. Certain syndromes have a higher risk of having scoliosis. So we don't know what is really the cause, but we do have some inputs of potential causes such as hormone abnormalities. Our own study was published earlier this year, and I think the Straits Times as well as Channel News Asia picked up on it, about how the brain can be responsible in some of the changes in scoliosis. And certainly genetic factors are important because we see that some families have more patients, have more family members having scoliosis. But the reality is we don't know because we have so many factors. And so therefore it's still known as idiopathic because we're not sure of the exact reason. We hope that, of course, in years to come, with more research, that this idiopathic word can be dropped and it will just be adolescent scoliosis because we know what's the reason. And because we know what's the reason, we should be able to have targeted therapy in the long run. So when I see a patient, I want to know, is there another cause of scoliosis? Is my child in the clinic here, is they mature or immature, and what is their growth potential? And of course, we recognize also to make sure that they don't have underlying syndromes such as hyperlaxity or neurofibromatosis. And I figure out whether they are mature or not based on some history. I ask them for the girls, when did your menses arrive or have they arrived yet? And if they have, then that means that there's some additional growth for another 2 years from the time of the menstrual cycle, first menstrual cycle. And after that, actually the spine growth stops, which is a bit of a disappointment for some of the girls because they want to grow a bit taller. But from the specialist standpoint, if their spine has stopped growing, the spine's scoliosis should stop worsening as well. And in boys, of course, there's no menarche, but then they have, we use the growth height as well as changes in the pubertal changes to try to have an idea of when is their growth phase. Of course, we have some x-rays to guide us as well. And we use some areas in the x-ray, the hip, as you can see here in the circles, the pelvis to help us figure out when is the growth completing, right? And if growth is completing, then we know that the patient has not a high likelihood of worsening. But if growth is still continuing, then we want to be able to manage it in a very specific manner. And of course, you can see this patient is not saying hello, but we're actually looking at the hand. And the bone age actually helps us figure out when the patient is more mature or immature. And as I alluded to this, immature patient should receive some sort of bracing if they're having a curve that is more than 25 degrees. But a mature patient should require some observation. However, if the curve is large enough and big enough and it's worsening, I think these are signs that will require potential surgical management. So intervention-wise comes from both physiotherapy, bracing, and surgery. I think that my focus today, of course, is most of our patients actually receive physiotherapy and bracing, and a small proportion requires surgery. And I think this should be very reassuring to our parents on this forum, because really the efforts is all about making sure that we can avoid surgery for your child. However, for the kids who are listening onto this, if you have learned some physiotherapy, please practice your physiotherapy because this is important and definitely a critical part of your care. right? And we aim to prevent progression. That's the most important. So some of the recent advances is, of course, we use low-dose radiation for scoliosis surveillance. June will share about shock exercises and physio-related specific scoliosis exercises. There are some growth modulation technologies. And of course, we use three-dimensional planning for our surgeries. So in SGH, we are very fortunate to have with us the next generation X-ray machine with the low-dose radiation, up to 90%, 80-90% reduction in radiation. The left image was the first generation one, which many of you have used at the Health Promotion Board. And this allows us to be able to do X-rays at very low dose and low risk of developing potential radiation-related problems in the future. So you can see how the traditional X-ray, where they stitch image together versus the version 1 in the center versus version 2, you can see that the image is getting better and better, but with less and less radiation. And I think that is exciting for me as a specialist, because we can continue to do X-rays for surveillance without the risk of our patients having any radiation-related issues. Now, bracing is important for patients who require it. They must be in the growth phase and they have a curve of 25 to 40 degrees. And most important is, of course, compliance, right? Because if they're able to be wearing it for the 16 to 20 hours a day, then that will make it work. And this is really proven through a landmark trial in the New England Journal of Medicine that showed that the more you wear, the better it gets, and 16 hours is important. When do we stop the brace? We stop it when there's no more growth, or when the patient shows signs of maturity, typically about 2 years from the time of menses starting. More importantly, I think what is hot off the press is there's no need to wean your brace. Yeah, you can just take it off when you don't need it anymore, because it's been shown that there's no difference when it comes to immediate versus gradual brace weaning protocol. Of course, patients who need surgery don't need to wear a brace anymore. In fact, I want them to do a bit more exercise so as to strengthen their spine before they go to surgery. Physiotherapy is well proven, and I think June will share a little bit about core strengthening, shock exercises, as well as physiotherapeutic scoliosis specific exercises. And once again, compliance is important. So all the kids on this Zoom, please remember to do your exercises after you have learned about it. All right, so I'll leave this for June to share a little bit more, but these are some of the schematic diagrams to show what is being done during Schroff exercises. It's of course well proven in terms of the effectiveness, and I think when we refer patients for this, it is not simply referring, but because we recognize that it's important in their treatment journey. You can see, of course, there's data to show, and all these studies, you see there's a 0 mark, they're all trending towards the 2 or 1 to 2, which means that it shows that there is proven effectiveness in the exercise therapy. So what about growth modulation? Is there a way to allow the faster growing spine to slow down and allow the concave side to catch up, which in yellow color? And can I preserve motion? Because the current treatment options are mainly fusion, right? So growth modulation is important because if I can stop the spine from growing on one side, allow the other side to grow, then definitely the patient will be self-healing in a way. And this is, of course, recognized because any growth area on compression will stop growing. And if there's traction, it will continue to catch up more growth. And this is a biomechanical principle, right? And so what happens in vertebral body tethering, which is the newest technology that we have, is to allow the spine to catch up its growth, and over time, allow the concave side to become straight. And this is seen here, as you can see. So this patient underwent gathering. You can see here, this is the motion that is preserved. And, the nice thing is that actually it allows biomechanics to catch up. So you can see my patient here is minimally invasive, and you can see he's very mobile and moving from side to side without any limitations of his mobility. Yeah. Minimally invasive because we use a thoracoscopic approach, and then we actually make some small holes in the chest which then gives us the ability to access the spine and to do the surgery. Now, not everyone is a candidate for this. We usually reserve it for those who still have some growth potential left. And you can see these guidelines here that are written about the patient. Inside the spine, it looks like that with a cord and a screw. And the scar post-op actually is a very small scar. And I think this is, to me, a big advance in terms of the technology and what we can provide for our patients. So this is an example of a patient who you can see over time caught up her growth, right? And as she grew taller, she grew straighter. And these are the cases that we really, really want to catch early to do this technology. In terms of surgical management, there's quite a fair bit of pre-op planning. We use MRI scans to help us. Sometimes CT is helpful, but most of the time I find that in normal cases, we don't need it. Some of the game changers that can help us, of course, is navigation. You can see on the left screen here is the low dose navigation that is unique to SGH. The cell saver, which is very important to give the patient's own blood back to them so that they can mobilize faster. And of course, nerve monitoring to make the surgery safe. These are the things I think that the important things that help us make it safe and make it smooth for our patients undergoing surgery. We are the first, of course, in SGH to have the O-arm since 2007, and that was version 1 with the orange color. And of course, now you have a version 2, which allows us to get in the pedicle screw into a very tiny pedicle, which is like that. And this is really technology that allows us to do so. We further reduce the amount of radiation because you are using a 3-dimensional low-dose X-ray. And we do not require any pre-surgery CT scan. So these are some of the videos that starting operation. You can see what we want. Place the components very safe. Safe and sharing. So in complex cases, we do sometimes need 3-dimensional printing, and that really helps us in making it safe. And of course, you can see here that sometimes we even put the model on the field in a sterile bag. So it's to help us do the planning. And I think Zaobao has picked this up for us in 2022 and how we are able to continue to do this in a very thoughtful manner and to make sure that our surgery becomes safe. We use 3-dimensional mapping using our machine that is the EOS, the one that you saw earlier. No additional data are required, but it really helps us in doing the planning on how we want to rotate the vertebral back when we're doing the operation, give them a nice result, as you can see here. So, aims of surgical treatment really, I think, is to stop surgical progression, correct the deformity secondarily. And of course, we have many happy patients who can continue to share our story with regards to the treatment of surgical management. So when it comes to follow-up, of course, it's not just a surgeon, there's a team effort, and the physios, the paraclinical staff, our nurses, all are highly important when it comes to managing the patient. And there are many resources for parents here. So there's an online resource that you can read more about, the SRS. There's an area here just for patients. You can see here patients and families in the bottom left-hand corner. And of course, I welcome parents to join the patient support group, which are on Facebook and managed by patients themselves. I think there are no surgeons inside, to last I checked. And of course, in conclusion, I think we want to share about the diagnosis, the observation. We've talked a bit about physiotherapy. I think it's important for those who are on physio to be compliant. Low-dose radiation is available for monitoring the patient's scoliosis. We definitely, if requiring surgery, require sometimes some 3D printing, but most of the time it's really quite safe, and we are very assured with 3D navigation to make sure that the operation goes smoothly. Lastly, we have motion preservation surgery now, which is minimally invasive, and I think this is really a good treatment for patients who are in that patient group that can have it. Okay, so any questions, you can always drop me an email, but of course there are many chances to ask questions later. And With that, I will end my talk. Yeah, thank you, everyone.
Thank you, Prof. Ruben, for sharing your thoughts on scoliosis and the current advances in the surgical treatment of scoliosis. I think it has dispelled a lot of um, myth or fear about spine surgery, especially to our parents, because the fear of going for surgery is always there. But I think with all the recent advances, it's actually not as scary as we used to think. But obviously, as what Prof. Ruben has said, most of our patients can be treated conservatively, and they all do well, with conservative treatment. And to share more about conservative treatment, we have now Dr. June Quek, who is our senior principal physiotherapist, and she will tell us what the conservative options and the physiotherapy approach to scoliosis. Dr. June?
Thank you, Dr. Ng, for kind introduction. Good morning, everyone. Thank you so much for making time to attend this talk on a precious Saturday morning. I acknowledge there's a mix of ages attending this webinar, and so for the purpose of this talk, I will address both adolescents as well as adults. So I'd like to start with a helicopter view where physiotherapy comes under the category of conservative management in cases where surgery is not indicated, and where surgery has been delayed, or when patients actually prefer the non-invasive approach. So generally, physio is aimed at reducing pain, improving function, and enhancing overall quality of life. More importantly, at a physiotherapy clinic, it is our goal to provide individuals with the tools and knowledge that they need to effectively manage their own health and well-being. However, in this talk, I can't cover everything what we do at physiotherapy, but I will focus a little bit more on physiotherapy scoliosis-specific exercises to address scoliosis, to help us understand a little bit more of our approach in treating scoliosis. So I will go through the what, the why, the goals and expectations, the how, what is involved, and who. So both adults as well as adolescents. Just to reiterate what Dr. Ruben shared just now about the definition of scoliosis, it is a complex process of trunk deformation which moves from a sagittal plane to complex torsional geometry in three-dimensional space. Often when we look at the X-ray, we're just looking at one plane. And it's really important for us physiotherapists to understand how the spine is deformed so that during the exercise sessions, we are addressing the deformed spine. So not just this plane we're looking at where the curve is rotated more on to the right on the top, left at the bottom. But we're also looking at the side plane where some people have huge kyphosis, that means big curve, or flat back like Dr. Ruben highlighted, as well as here the low back, either hyperlordosis or hypo, so increased curve at the bottom or reduced. So I always tell my patients, no patient is the same and no curve is the same. And so when you come in for treatment, we actually have to individually assess each person and then very specifically cater the exercises to each curve. So let's move on to the physiotherapy scoliosis specific exercises. Most commonly known as Schroff exercises. This is exercises. So this exercise was actually invented by Katrina Schroff from Germany in the early 20th century. And she developed it for patients with scoliosis and spinal deformities. However, since then, there have been many schools that have popped up addressing scoliosis. They all are scoliosis-specific exercises. They just have different branding. I'm trained from the first school, but there are many more. Yeah, so I think there's no one school better than the other school. But it is important to understand too that this form of exercise is actually not taught in the undergraduate program. Physiotherapists need to undergo specific training in order to be able to teach this set of new skill set. Let's move on to the goals and expectations. During the first session at physiotherapy, I would establish the goals and expectations so that the patients and I and the parents will be on the same page. The first goal obviously is to avoid surgery for many, to prevent and delay further progression of the spinal curve, especially in the adolescents. Yeah, and lastly, and very importantly, to help patients to be aware of their posture, so that we are not perpetuating the asymmetrical posture that they adopt. So many patients actually are unaware they are leaning towards one side or standing more towards one leg because they're so used to it. And their center, where they see center is actually warped. So they are not aware that they are not centered. So actually, we need to highlight to them and bring to awareness that this is where they are standing or sitting, and to correct themselves on a daily basis. Other goals that we would like to achieve during the session would be to increase chest mobility and respiratory function. It's been shown from research that patients who have scoliosis do have a reduced lung capacity. And the reason is because if you look at the X-ray on the right here, if the curve is convex and curved towards the right, the lung on the right will be expanded, so more elongated here, and the lung here will be more compressed. So you will see in this case that the lung on this side will actually be reduced, and therefore there's less chest expansion. And so we have to bring to awareness that this side is actually breathing less air, and to train the muscles to expand a little bit more on that side. Yeah, and so breathing techniques are really important in our clinic when we treat scoliosis. And Dr. Ruben actually mentioned many times about compliance, about exercises, and thank you so much. That's the biggest problem that we have in clinic, that patients actually find it hard to comply with exercises, but it has been shown in research that compliance is associated with better outcomes. And the other thing is we are not just treating the patient or the curve, but we're looking at a multidisciplinary approach, not just the patient, the parents, the surgeons, as well as the orthosists. Yeah. What we cannot do in the clinic is to reverse the spinal curve. Of course, we hope that miraculously the curve will go back to the center, but it's quite unlikely. If we are able to prevent progression of the curve, I think that's really, to me, a success story. As Dr. Ruben talked about, it is time sensitive, especially in the adolescents, that we want to capture the window opportunity of treatment. And that is about 1 to 2 years before puberty and 1 to 2 years after puberty, because this is where the patients actually have the growth spurt. The other things that we look out for in clinic is things like biomechanics, foot posture, leg length discrepancy, and also what is the patient's goal. Many patients actually don't really care about their curve, but many do. So, aesthetics wise, some are more conscious and some actually say, no, I think I'm quite straight. And actually that it's a difference between I find in clinic, for those who are more athletic versus those who prefer to be more sedentary, those who are more athletic and stronger, more muscle bulk, actually do better in terms of understanding the exercises and being able to engage the exercises to a desired outcome. Yeah, so in general, it will be better to be more active. And I encourage all my patients to be, to adopt an active lifestyle. So I thought I would want to share with us an example of what we do in clinic with this 13-year-old female who's also concurrently wearing a brace. You can see that on the picture on the right, on the left, her curve is convex to the right and then concave to the left. Her hip is shifted more, the pelvis more to the left, and then the top part of the body is shifted more to the right. And that's a coronal plane. So you see flat on this way. And if she bends forward, you can see that she has a level of rotation in the spine as well. The right side is higher when she bends forward. Okay, next. So this is an X-ray on the left. As I mentioned, concave, convex to the right and convex to the left at the bottom. Okay, and what we do in clinic is if you see that the patient is lying on her left, and before we make adjustments to her lying posture, not very clear here, but you can see that her spine dips, oops, sorry. Her spine dips this way and then curves this way. Like during the exercise, we try to realign the spine by putting a towel here underneath the bottom, using the shoulders as a way to engage the muscles to realign the spine towards the center. Okay, I'll give you an example of a video of what we do. Okay, so first step is put the towel under your left butt. Okay, then elongate your spine. Okay, shift your right trunk center, good. Okay, and then now use your hands to correct your curve. Push your left hand. Yep, don't lose your corrected curve. Yep, elongate. Okay, good. Elongate, good. And breathe. Good. Don't lose it. Yep, elongate. Elongate. Yep. Don't lose. Okay, so this is a snapshot of what I took during the video. So before, it's a picture on the left. So she was just sitting as her usual. And then just during the exercise, the idea is to realign the spine towards the center. You can't really see, but she's actually facing a mirror. So she can actually use the mirror as a feedback to realign herself. So mirrors are really, really important in when we are teaching this kind of exercises. So success of scoliosis-specific exercises really depends, highly dependent on the compliance and commitment to exercise and maintaining postural balance. So it's not really good if you just do exercise and then the rest of the time you're slouching and leaning towards one side. And so we want to reinforce and reiterate all the time for patients to be aware of how they're sitting, how they're standing, how they're walking, so that they don't perpetuate that asymmetry and to bring themselves and aim to bring themselves more towards postural balance. And if you are given a brace, so compliance with brace is really, really important, at least 16 to 18 hours a day. I find that it's more effective with patients who are wearing brace and doing the exercises at the same time. They actually give a much better outcome. Supportive parents are those parents who actually are more involved in the patient's rehab, you know, do the exercises with them, give them feedback, encourage them. I think this group of patients actually also do better. Regular physiotherapy sessions. Generally, these exercises are really hard, as you can tell from the video. It's not like first session that the patient was able to do that. It takes a while for the patient to understand, first of all, where their curve is, and then how to move their curve towards the center. So usually around 6 to 10 sessions as an estimate. And this is over, I don't know, a year or 2 years. But the first, usually we will try to see the patients at least once a week for the first month. The frequency is really important for the first month. And then after that, subsequently, we can spread it out as the patients get the understanding of the exercises. So the exercise, the experience of the physiotherapist is also very important. But I must say that scoliosis-specific exercises in Singapore is emerging field. It's not been around for too long, but I think the longest one is KK and NUH. SGH only restarted recently, the past couple of years. I thought I also want to share with you guys a scoliosis camp that we just conducted last month. Yeah, it was a 3-half-day camp. And basically patients would come and do the exercises for 4 hours a day with breaks in between, of course. Yeah, because doing these exercises is actually very, very tiring. I wanted to emphasize that the intensity and duration of the exercises are really, really important in getting the best outcome. So the camp really showed me that significant improvement in a very short period of time. Just to illustrate that, this is a 15-year-old boy who attended the camp. So the picture on the left is before in the front, and this picture is after. You can see that his the rotation of the pelvis improved quite a bit, and he's a bit more lifted in terms of posture. In the back view, the view on the left, we can see that he's also more kinked here and improved on the right. Yeah, he also felt that he was more aligned. It's just a subjective feeling, but that's really important for patients to see the benefits and the significance and the impact of the exercise, so as to motivate them to continue to persevere until the point where they are out of the growth spurt period. From then on, they can continue to do exercise, but perhaps we can reduce the intensity and the frequency after they pass the puberty period. So let's move on now to scoliosis in adults. Unfortunately, scoliosis in adults is quite complex, and the reason is because it's complicated by things like osteoporosis, pain, deconditioning, and lifestyle factors such as diet, smoking, lack of sleep, stress, and sedentary lifestyle. However, patients often come to us not really because their spine is curved, but usually it's because they have a significant pain and dysfunction. That's why they go and see the doctors, and then they are referred to us. In general, we can treat them with both general exercises as well as scoliosis-specific exercises. And it's important to know too that it's not possible to reverse the curves. They have been living with these curves for so long. And I think the best that we can do is really to help them to improve their posture and also to prevent the curve from getting worse. However, this is quite a complex issue because there are many, many factors that are really out of our control. Exercises are definitely, in my experience, seem to be effective for pain mainly. And there isn't much evidence at this point to actually definitively say that we can prevent the progression of curve. It's just that not much research has been done. It's not that there isn't evidence, it's just probably not done. The research in this area is not bountiful yet. Yeah, the treatment is pretty much the same to help patients to be more compliant with the exercises and postural balance. Encourage the patients to be physically active. And because of osteoporosis, as we grow older, it's important to include weight-bearing exercises as well. I give you an example of a patient, an adult patient. This is a 48-year-old female with a lumbar curve of about 30 degrees. So this is her usual posture on the left, and then on the right is the posture that she's adopting when she's doing the exercises. You can see, I just drew the line there for you to be able to see. That's her curve, about 30 degrees. I don't know whether you can see from the picture that the pelvis actually shifted more to the right and upwards. So if you put your hands on the pelvis on the right is higher. Yeah, and the goal for the exercise is to get her to be taller, elongate herself. So I often use the word elongate, not to push your chest forward, but rather to make yourself taller. And as well as to shift her pelvis more towards the center and drop her pelvis downwards. So this is a video I took of her walking. So we just have a look. Just take a look at her right pelvis here. It's very much shifted to the right. Yep. And you can see it's very close to her hand. Okay, and then in this case, I got her to loosen up, swing her arms, be a bit more relaxed, and shift her pelvis more towards center, and to make herself taller. So you can see that just by giving some cues, she's able to then realign her posture to the center. So this is what we try to do in the clinic. It's not as simple as that when patients are complicated with pain and they can't get into that position, but if possible, we will try to realign them so that they are able to understand what is center. So this is a snapshot of the videos there. You can see that her pelvis is shifted to the right on the left picture, very close to her arms. And you can see just look at the belly button, that is more centered on the right. And the body is actually like more elongated and taller. Lastly, I just want to address this thing on scoliosis-specific exercise versus general exercises. I would say that in the adolescents group, scoliosis-specific exercises have been proven to show better results in COP angles. However, in the adults, this evidence is still lacking and is complicated by many other factors. And it really depends on how long the patients have had the curve for. Many people actually function and thrive well with scoliosis throughout their lives. It's usually during their 60s and their 70s, then they start developing all these issues and the progression of the curves. I mean, from my personal experience, can't quote me on that in terms of whether it's true in terms of evidence. But I think the reason is because of as we grow older, it's generally associated with reduced physical activity, as well as the onset of osteoporosis. Your bones get weaker, and therefore it's more less support coming from the passive structures. The other thing that I also notice is that patients who are, we are all subjected to, as long as we are staying on Earth, we are all subjected to the effects of gravity. So as we grow older, we become weaker, not just the spine, but generally your body, your legs muscles, your trunk muscles, they are all, they generally get weaker. And so if you are weaker, it's harder to resist the effects of gravity. So in general, my advice is really to engage in general physical activity so that you don't get weaker and you stay strong, and to prevent the worsening of scoliosis and adult spinal deformity. So that's the end of my talk. I'd like to acknowledge Dr. Beek's Orthopedic Surgery Department of SGH, who has given us a lot of support in developing this service. The physiotherapy department has been really gracious in supporting the start of this service as well. KK Physio Department has given us a lot of insights as well. And most importantly, I'd like to thank the parents and patients who gave permission to use their photos and videos in this presentation. Thank you.
Thank you, June, for sharing with us the different physiotherapy exercises for patients with scoliosis from the young to the old. I think that was very helpful, especially with all the videos. So up next, we have Dr. Ouyang Yo Heng, also one of our consultant spine surgeon, who's has a special interest in adult spinal deformity management. So Dr. Ouyang will share his views and on those patients who has developed, adult spinal deformity in their later years and what are the available options. Dr. Ouyang.
Hi, good morning, everyone. I'm a consultant spine surgeon with the Singapore General Hospital, and I'm very happy to talk about adult spinal deformity management. I'm a medical consultancy with Stryker, which is an implant company, but I don't think it's relevant to this talk. So what is adult spinal deformity? And essentially, adult spinal deformity is a spinal deformity in a skeletally mature patients, or otherwise known as adults, and they can have a coronal Cobb angle of more than 10 degrees or a sagittal vertical axis angle of more than 5 centimeters. And this is what it looks like. And I'm sure you've seen this in Prof. Ruben's talk previously. This is a view from the side, and you can see that the patient has hunched forward and is tilted forward. So the first question to ask yourself is, what is the difference between adult spinal deformity and adolescent idiopathic scoliosis? Is it just the same deformity but in an adult body? And the answer is not really. So on the left screen is a patient with adolescent idiopathic scoliosis or child scoliosis, and on the right is a patient with adult spinal deformity. And you can see that the curvature is actually less in the adult patient. So if you were to do an operation to try and fix these curves, you would realize that the pediatric or the adolescent idiopathic scoliosis patient would only experience about a 1.5% risk of complications, whereas the patient with adult spinal deformity would have up to 34% risk of complications, and this is a 2,200% increase in complications. So why is this the case? Well, it's because of the differences in how adult scoliosis is developed. And typically in pediatric scoliosis, the intervertebral disc, and these are rubbery things between the bones of your spine that allow you to move about, they tend to be healthy. But in the adult population, due to aging, wear and tear, and excessive use, these discs can start to become smaller, more stiff, as well as decrease their height. And if you can look at this scan, which is an MRI scan, you'll notice that as the height of these discs decrease, the shape of the spine goes from a nice C shape in the lower back to something that is more flat, and we call this a flat back deformity. So the second thing that can cause adult spinal deformity is something that affects the bone itself, not just the disc. And this typically is due to osteoporosis, which is a reduction in the bone mineral density. And this leads to fractures of the spine, subtle small fractures of the spine, which then lead to a progressive increase in the hunchback. The third cause of adult spinal deformity is actually a progression of a pediatric spinal deformity or scoliosis. And as the effects of time, gravity, loss of muscle bulk in the later stages of your life, this scoliosis can start to worsen later in life. And lastly, the last cause of adult spinal deformity comes from inflammatory arthritis. And this is where autoimmune antibodies, the same antibodies that your body uses to fight infection, they unfortunately get switched on inappropriately, and they start to attack the bone, the disc, as well as the soft tissues around the disc, which leads to a deformity of the spine. So why does this all matter? And it matters because humans, we stand upright because of this thing called the savanna hypothesis, whereby our prehistoric ancestors had to peer above the tall grass to catch animals, and that actually led to us freeing up our hands, being able to run with a more energy efficient gait with two legs, gaining the ability to carry tools as well as weapons. But this also led to some downsides, which is that a two-legged animal is inherently less stable than an animal that walks on four legs. Our center of gravity is higher, and we have a very narrow base of support. So in the 1970s, this concept known as the cone of economy was developed by a French doctor, Dr. Debussy, which stated that as you tilt the top half of your body in an outside manner or in a cone, in order to be able to stand upright, one would have to have more muscular activation. And this muscular activation is kind of like standing in a horse stance for a long period of time. And that tends to give rise to pain within the muscles of the spine, which help you to stand upright. Now, the other problem with having a deformed spine is sometimes a loss of the ability to look forwards, and this can give rise to a patient that will frequently bump into people as well as trip over items. And as the disc heights decrease in height, foramen, or rather the openings or where nerves come out from the spine, can become narrowed, and this will trap the nerves, giving rise to pain and weakness in the limbs. So what is, your lifetime risk? And the prevalence of adult spinal deformity is between 3 to 30%, depending on your age group, anywhere from 40 years all the way to 80 years and beyond. So what can you do? So as Dr. June mentioned, and Dr. Ruben, I think exercise of core muscles has been shown to both reduce the progression as well as reduce symptoms. And one should actually engage in frequent stretches and movement. And this is because the spinal disc, which is the commonest cause of adult spinal deformity, is a kind of a fluid-filled structure that acts a bit like a sponge. So as you move your body about, it actually imbibes in fluid, and this fluid brings about nutrition as well as oxygen that allows the disc to continue repairing itself. The second set of lifestyle changes is to avoid smoking. Smoking actually reduces the blood circulation to the disc. Avoiding obesity as well as adopting a good posture are ways to decrease abnormal loading on the spine and the disc. The next category is means to avoid osteoporosis. Osteoporosis, building bone in the body, requires both sunlight and vitamin D, as well as calcium supplementation, which we can get from milk as well as meat sources. Avoiding excessive alcohol intake, and you can actually go for bone mineral density screening above the age of 65 to check whether you require some additional medication. So when should you see a doctor if you've got a spinal deformity? Actually, this is not an easy question to answer, because if you are actually quite comfortable and you have no symptoms, you're able to walk about, do your work and your daily activity, you don't really have to see a doctor. And indeed, many people around the world suffer from quite severe deformities, but are able to go about their lives. However, you should see a doctor if you are getting worsening symptoms, you have a new onset of weakness or numbness, or difficulty passing or controlling your urine or your motion, a worsening curvature of the spine, a sudden loss of appetite, a loss of weight together with back pain, and lastly, prolonged fever as well as back pain at the same time. So what will happen at the doctor's office? So in general, we will take a comprehensive history. Number one, finding out what had happened to your back, how it's affecting your life, and what you expect. Then we'll send you for some additional imaging like X-rays, as well as advanced imaging like MRIs or magnetic resonance imaging. After having diagnosed the cause of your pain, which can either be due to the deformity itself or nerve compression, treatments can include painkillers, physiotherapy, injections, acupuncture, even some things like a nerve root blocks. Surgery is the very last resort, and I would like to share a bit more on this topic. So as I mentioned that the difference between a pediatric spinal deformity and adult spinal deformity is the genesis of the problem. The second difference is that adults tend to have additional medical problems such as cardiovascular or respiratory health problems. They have anemia, which is conventionally known as low blood, kidney disease. They may be smokers or heavy smokers, and patients may have osteoporosis with poor bone quality. When you do a large deformity surgery, bleeding is a huge problem. And as you can see, even in good international centers, you can lose up to 40% of the blood volume if you're doing a large correction. You get nerve injuries when you're operating near to the nerve, and sometimes the nerves can be torn, giving rise to a leakage of a fluid from the brain, and this can be a very scary and occasionally fatal complication. Even if you have avoided immediate complications during surgery, after surgery, the screws can start to loosen and you can start to develop fractures above the level at where surgery was conducted, and this is otherwise known as proximal junctional kyphosis. And if the patient is revised multiple times for back pain, the patient may have what we call in the community as a failed back syndrome, in which case continuous adding on of surgery every 2 or 3 years to keep extending the construct upwards can happen, and this is very disabling and very distressing to a patient. So what are the indications for surgery? So first would be a progressive deformity, intractable pain despite other measures, the presence of weakness or numbness or neurological deficits, and lastly, the patient has to be medically fit. I would suggest that such surgery is never done for cosmetic reasons, as the risk can be quite high at up to 34%. So what are the aims of surgery? So firstly, we aim to reduce the deformity, and this is to allow us to improve standing efficiency. The second aim of surgery can be the decompression of nerves, which provides a relief of pain as well as an improvement in function. So how does the surgeon plan for such surgery? Well, I mean, just comically, study and practice and years of it, as Dr. Strange famously said. But realistically, I think the main question that most surgeons ask ourselves is, how can I do the least for the most amount of benefits without complications? So the considerations in adult spinal deformity include the extent, the location of it, the technical capabilities of the hospital and the surgeon, as well as the surgical approach. And these surgical options include, surgery from the back or the front, whether it is in 1 stage or 2 stages, and whether it can be done either open or minimally invasive. Now, minimally invasive surgery, otherwise known as keyhole surgery, sounds very attractive. It might have faster recovery, less tissue trauma, similar or better outcomes. However, keyhole surgery is, as the name implies, looking at something through a very small opening, and that can sometimes give rise to difficulty in seeing a bigger picture or a bigger view. And this might actually lead to a longer operation that is more costly and has a higher complication rates. So therefore, when planning anything with minimally invasive approach in mind, there's something called an MIS benefit zone. And this is depending on the complexity of the case. And in general, as the case becomes more complex, MIS decreases in its utility. Even the name itself, keyhole surgery, is a misnomer, as actually you can see that the scars from surgery, either open or minimally invasive surgery, can be quite comparable. What's more important to take away from minimally invasive surgery is the philosophy, which is that we try to minimize the amount of tissue trauma to get to the surgery that we intend without causing too much additional damage. So I would suggest that a combined approach is to take philosophy from both sides, to consider both an open procedure or minimally invasive procedure, and know that the treatment is driven by the patient and the pathology and not the technique or the technology. So I'll quickly run through some of recent advancements in terms of the technology that helps us to achieve better surgery. We have navigation, which allows us to put screws precisely. We have machines that collect blood during the surgery that can be returned to the patient. We use electrical monitoring of the spinal cord function during surgery, and this gives us an idea of nerve injuries that may occur, and we can take steps in the operation to try and reverse this injury. We use special advanced implants, and there are new correctional capabilities on the horizon with specific bent rods to get the right kind of shape for the patient after surgery. Recent advancements include robotic-assisted surgery, whereby robots are used to place screws even more accurately. And lastly, endoscopic surgery, which is added on to allow us to do decompression with even less tissue trauma. In the future, AI is changing the world, and we can have AI automated spine landmark templating and parameter marking. And AI may also give us deep learning in predicting how each individual patient might have complications after spinal surgery. I will skip this case study, but my take-home message is that you need to take care of your back and bone health, adopt movement and muscular strengthening daily. Surgery is the last resort, and the results are worth it for the right patient. Thank you very much.
Okay, thank you, Dr. Oh Yang. I think you have given us a very comprehensive review of adult deformity, and I think the surgical aspects have probably frightened a lot of our audience. But I would say that surgery is usually the last option. It's not as risky as it probably was many years ago. And I think if we select our patients well, I think the patients usually do benefit if the surgery goes well. So we'll proceed with our Q&A session. There are some questions that we have tried to answer in the box, but I think one of the questions that keep coming up, we'll get Dr. Jun to answer this. Dr. Jun, does chiropractic treatment help with scoliosis, and what are your thoughts on chiropractic treatment?
Hi, thank you for the question. I get this everywhere I go. So I'm not a chiropractor. I cannot really answer whether or not chiropractor treatment is effective. But in general, my understanding of chiropractor's philosophy and approach is to help with pain in the spine, and many of the problems that come in the body is as a result of the spine. And so I think the treatment is usually targeted at spine, and I think some of the chiros actually claim that they can realign the spine. I'm not sure if there's evidence for that. But for patients who go and they report to me, many of them actually do report an improvement in their pain and function. Yeah, and I think it's quite similar to other alternative conservative treatments like acupuncture, traditional Chinese medicine. Whatever works and helps, I will not object to it. And I encourage my patients to go for it so that they have a window of opportunity of a pain-free period, that they can use that period then to engage in exercises so that their body is stronger and has more endurance to improve on their overall physical health. I guess the problem with the passive modalities, which means that you're not doing anything, someone else does the treatment on you, is that you're very reliant on someone else to help you. And not only that, there's also financial constraints. So the best approach would really be that you get improvement in your pain and you're functional enough to start doing some simple exercise and slowly make progression in equipping yourself with the tools to maintain or to improve your general strength and fitness. Yeah, I hope that answers the question.
And for patients with scoliosis, what are the exercises that you generally encourage? Because we have a lot of young patients, they want to play tennis, like one parent was asking, they want to swim, what strokes and all these things. How will you answer to these questions?
So if the curve is quite minor, I think general exercise is sufficient. But if the curve is quite big, I would say more than 30 degrees, then I would say that you should engage in scoliosis specific exercises. However, I think the evidence has shown that the smaller the curve, the more effective it is. Yeah, and it's a tricky situation because a lot of my patients who come and learn these scoliosis specific exercises often struggle with complying with the exercise regime. And I mean, I encourage them to do 45 minutes a day. It's quite a hard ask. And so I understand that it is quite difficult to actually comply with that. But if anything less than, half an hour to 45 minutes, you really don't get a lot of benefits. And so in that case, then I would say, yes, then go ahead and do general exercises. Any exercise is good. Swimming, tennis, running, walking, they're all great. Even just going to the gym, lifting some light weights. The guideline is that you want to start low, slow, and slowly progress. Don't suddenly go and do like, really hard pumping sessions with your weights. Yeah, so doing something is better than nothing because a lot of kids tend to like to use their time to play computer games instead of doing exercises. So I'll say that I'll try, to weigh the pros and the cons that they what is sustainable and what is realistic, and I'll try to work with that. Yeah, so I hope that answers the question. So the answer to that question is very complicated by actually patient circumstances and interest and willingness to be on board the exercises. Yeah.
Okay. And Prof. Ruben, everyone is very excited about your holiday camp. Do you have any updates on your holiday camp? And can older patients attend, as one attendee was asking?
Actually, this one I would probably hand over the question to June, who was the one who created the scoliosis camp. The main focus, I think, was mainly to do it during the school holidays so that we can address many patients in one visit, and also there can be some peer support for each other. So maybe June, you want to share a bit more about the scoliosis camp?
Yep. So thank you for your interest. We only started the first camp this year. And it was a trial run to see whether it is a good take-up rate. We maxed out the number of participants that we wanted. And so we are hoping to have at least one camp per holiday. Not sure about September holidays. It depends on our manpower situation. But in order for you to attend, we had one adult attending. So yes, adults can attend as well, but we will not bring you cold into the camp. Meaning that you need to have at least a few sessions with the physios individually so you understand the exercises, at least some exercises, so that when you go to the camp, you're not confused and that you maximize the time that you have there. Yeah, so I would encourage at least 2 to 3 sessions before attending the camp. Yeah, I find that yeah, the adults is more challenging in terms of managing the pain as well as the curves. Yeah, but in order for you to attend the camp, I would like the pain levels to be under control so that we are not struggling with the pain while doing the exercises. Yeah, so we need to at least see you individually first before you can attend the camp.
Prof. Ruben, will pregnancy worsen the scoliosis? And what advice do you have to our childbearing female patients?
So scoliosis doesn't usually worsen during pregnancy, I think. But then if the patient already has some backache as a result of some injury in the past, or they already have backache to begin with, then of course pregnancy will worsen the backache. Then I think maybe the extended question that many parents also ask is, does scoliosis affect childbearing? The answer is no. Does scoliosis affect epidural anesthesia for normal delivery? The answer is also no. So actually the child can go on, have children and have normal delivery in a normal way. And so that I think can reassure the parents and also those who have scoliosis who are on this Zoom meeting.
Yep. Oh, do we still have more time to answer? Okay, so I think at the end of it, the whole purpose of this webinar, I think we can come up with some take-home messages. I think the whole idea is to be aware of this condition, and we know that it is a progressive condition, all right? And with early detection, with preventive measures, with regular surveillance, I think we can achieve a good outcome for most of our patients. And we have come to realize that most of our patients do not require surgery for scoliosis. And if you do come to a stage where it becomes more severe, more debilitating, and it's affecting your function, we do have surgical options available. And with the advances now with the surgical treatment, I think the surgery is not, the risks are kept low. But of course, as with all surgery, there will potentially be some devastating consequences. But I would say most of patients do benefit from surgery if the surgery is properly done and is done for the right reasons, right? Are we going to conclude this webinar? Dr. Prof. Ruben or Dr. Ouyang or Dr. June, do you have any take-home messages?
I think for a start, maybe we can share that this video will be on to YouTube. So for those who want to rewatch, they can have a chance to rewatch it again. And I think we've tried our best to answer as many questions as possible. So thank you, Yong Hui, for moderating and for jumping through the questions to pick out the important ones.
Yeah. Dr. Ouyang, Dr. June, anything to add on?
So I think for adult spinal deformity, it can be quite disabling. And if you have symptoms, it is a good idea to get it checked out. And while I did say, surgery can be quite intimidating, however, with the right indications and the right surgery, most of the patients do tend to do quite well. So that should not deter you from pursuing surgery if you are fit for it. Thank you for your time.
For me, I think prevention is better than cure. So if you already do have an existing curve, do really prioritize your body, spend time building up, doing exercises on a regular basis, at least 3 to 4 times a week of moderate intensity exercise. No exercise is bad. I think the only issue is sometimes we tend to overdo, and we overestimate our abilities. So you want to start slow, go slow, and slowly progress. If you do have pain and a curve, and you do want to try scoliosis specific exercises, there are many avenues to actually consult a physiotherapist. With SGH, I think we need a referral from the surgeons. So you need to see an orthopedic doctor first before they refer it to us. And it will be good also that you have an X-ray done. And they can kind of monitor you over time. I think there are many other private clinics that also offer. KKH and NUH also does offer scoliosis specific exercises. Yeah. Thank you so much for attending this webinar.
Okay. Thank you, everyone. And thank you, everyone, for joining us this morning. I think we will conclude this webinar. If you have any questions, feel free to email any one of us. And if you like to see us, if you would like the subsidized care, you have to go to polyclinic or some participating GP clinics that will do the subsidized care referral. But if you are okay to pay private rates, then you can call up our central appointment hotline, or you can email our patient liaison center, and we can always fix an appointment with one of our spine surgeons to address all your questions. Okay. Hope everyone has a good weekend. Thank you, everyone. Bye-bye.
Thank you.